thank you for joining us for today's webinar, Dementia in Focus. My name is Carissa, and I will be your host today. Today's webinar is presented by Safe Care BC. We are an industry-funded nonprofit association working to ensure injury-free, safe working conditions for continuing care workers in BC. So Safe Care wants to start today's webinar by recognizing that we are gathered on the ancestral and unceded territory of First Nations, Inuit, and Métis people across BC. We thank them for being good caretakers of the land and allowing us to be visitors on the shared territory to do good work. Before I introduce our speakers, I would like to cover a few housekeeping topics. So number one, today's webinar is being recorded. After the event, we will share a link to the recording, slides, and any additional resources, which we will also pop in the chat. We encourage you to revisit the content, and share it with your colleagues. To minimize distractions, we have disabled attendee cameras and microphones, but don't worry, you can still talk to us using the Q&A button at the bottom of the window. And if you think of a question for the speakers at any point, just type it in there, and I will either pose it to our speakers, or we have a Q&A portion at the end where you can save it. So in this webinar, we will be hearing from Susan Prosser, who has completed her BA in Recreation and Leisure Studies for Special Populations at the University of Alberta. She subsequently worked as a recreation therapist in seniors living and long-term care environments, eventually joining the Alzheimer's Society of BC as a support and education coordinator. In 2022, Susan joined the education team at the Society and now focuses on building and presenting educational workshops to community organizations and professionals, including healthcare workers. Sarah is not speaking today, but she will answer your questions below in the chat. Sarah Evaneshan, who is the manager of advocacy and education at the Alzheimer's Society of BC, is responsible for leading the organization's advocacy, public policy, and education team. Sarah has held several roles at the Alzheimer's Society of BC, including direct client support, program development, and project management. Sarah is a credentialed master in Deuterinology, a Bachelor of Health Science, and a certificate in project management. So today, Susan will be speaking about a case study which will explore the experiences of a resident living in long-term care home. This resident will often walk into people's rooms while searching for something. Through this case study, we will learn how behavior often communicates important information. When we investigate and begin to understand possible reasons for this behavior, we are able to provide helpful strategies. With that, I'm going to hand things over to you, Susan, who's going to start today's presentation.
Thank you so much, Carissa. Welcome, everybody. It's really good to be here with you today. And thank you, Sarah, for being here. Sarah's got her eye on the chat box, folks. So you can submit questions two ways. One, through the Q&A, where Carissa will get them, and two, through the chat. And there's going to be times during this presentation where I will be directly asking you for input into the chat box. So really looking forward to getting your input there. Now, Carissa, my screen has changed and my notes have disappeared, so just give me a minute. Something has happened as I handed that over to you. Okay, I'm back on track. So this is called Building a Strong Foundation for Dementia Care. And you know, I'm Susan, and you know, my colleague Sarah is with me today, and we're delighted to be here because we're actually following up on something called Care and Connections, which is an online learning curriculum available on the Safe Care BC learning management system. So if you haven't taken a look at Care and Connections, please do. This is a follow-up. It's going to build on that knowledge. Today, we're going to start with learning a little bit about dementia and just a short review of some of the concepts that were included in the Care and Connection curriculum. And our time today is meant as an introduction to understanding behavior. We could actually sit here, and I know you know this, for 3-4 hours working on this highly complicated subject, but today is just an introduction. We hope it's the beginning of building a skill set for healthcare teams to not only understand the dementia, but to start to develop skills around observing, describing, and understanding the behavior. We're focusing on this approach because behavior is a form of communication. It tells us something is going on, something that's changed, and often there's a problem that we need to understand. We're going to practice observing and describing behavior using a case study, as Carissa explained. The case study today will be of Nick, who's a gentleman living in long-term care. We will then apply person-centered language to help us identify what might be influencing Nick. And from there, we'll move on to maybe thinking about strategies that could help. Finally, in the end, we want to connect you to our website because there's some amazing learning on our website, and you can keep learning, keep reading, keep watching videos, and carry on. Now we're going to stop here just because this is a follow-up to Care and Connections, and Carissa is going to throw in a little questionnaire for us.
Yeah, I can for sure do that. I just wanted to make sure. Are you screen sharing at the moment?
I am.
Okay, I don't think I can see your screen. This is just a me issue. But I can launch the poll in the meantime.
Did you not see my screen anytime during the presentation, Carissa?
I cannot see it.
Perhaps we should check with our audience just to see if they can see the screen.
Yes. Yeah, okay, it's not just a me problem.
Okay.
That's great. We can
Okay.
see it now.
Susie, we can see your notes side, so I think you just might want to flip the screen there.
Thank you kindly.
Okay. I'm going to go ahead and launch this poll now. Okay. Now
Okay,
everyone,
thanks so much.
awesome. Can you all see the what is dementia? So there's 4 questions here. Looks
Here
like
we go.
we're getting some answers to it,
All
which is
right, this is
great.
great.
First question, dementia is a normal part of aging, true or false? Memory loss is always the first sign of dementia, true or false? There are over 100 different types of dementia, and another last behavior is a form of communication and is helpful to investigate any change in behavior before trying to change it. We'll leave it on for a few more seconds here just to get some more respondents.
We have 60 people on today, Carissa. That's amazing.
Yeah, no, that's awesome. 65 at the moment.
All right. I'm going to start to jump in and just move through these. So the
You
first
can,
question is, sorry, Carissa, go ahead.
sure. I was just saying, can we all see the results of the poll?
I can see the
Okay,
correct
awesome.
answer. Yeah,
Awesome. That's great.
great.
You can go through it, Susan.
Okay, so dementia is a normal part of aging. The correct answer here is false. There is nothing normal about dementia. Dementia always occurs after there is some kind of problem in the brain. And the problem in the brain could be Alzheimer's disease, which many of you have heard about, but it could be other brain diseases. So first there's the disease, and then there's the dementia. And that means that not everybody is going to get dementia because it's not normal, it's abnormal. Many of us will grow old into our old age in life and never get dementia. So the first one is false. Our second question is memory loss is always the first sign of dementia. Now, this is a trick question, and we put it in here on purpose because the answer is false. There are dementias that don't start with memory loss. They start with different symptoms, and this is what makes dementia so complex, is that you're going to get different symptoms, different signs at different stages in different people. And so many of us think of the memory loss, specifically the short-term memory loss associated with Alzheimer's disease. That's what we see most, and that's because Alzheimer's disease is the most common form of dementia. But when somebody has frontal temporal dementia or Lewy body dementia, they are not going to present with memory loss as a first symptom. It's going to be different things such as changes in movement, facial expression, sleep patterns, perhaps hallucinations, or radical changes in mood that don't make sense. So that was a trick one, and I'm glad we covered it, and you did well. Carissa, I can see two, but I can't see. I think there's another question. Thank you. There are over 100 different types of dementia. Now, you only have a single choice on this one. And I'm looking for the answers, Carissa. True and false. Yes. You would not believe how many different types of dementias there are. So yes, there's over 100 different types of dementias is correct. And I think I have one more. Anything else there, Carissa, or have I got them all?
No, I think you have the fourth one, which is behavior as a form of communication.
Thank you. Sorry, I can't see that one on my screen right now. So is behavior a form of communication? You bet it is. Because people living with dementia will most likely experience changes in their ability to communicate with us, maybe not at the beginning, but as the dementia progresses, other forms of communicating besides talking and dialogue occur, and that would be behavior. Behavior tells us, as we're going to discover today, lots of things that are going on with the person with dementia. It can convey a problem. It can convey comfort or discomfort. And learning to look at behavior and value it as key information to help us deliver better care is our goal today. Thanks, Carissa. I'm going to move on to the next slide. Marissa, is there a way that I could share and that this slide can disappear?
Are you currently sharing your screen right now? You should just be able to switch it within PowerPoint. It's on the blank screen still.
For some reason, Carissa, it just keeps giving me the poll.
Okay, you can stop sharing and then try sharing again.
Thank you.
It's a Monday morning, bound to have technical.
Here we go one more time.
There
There
you
we
go.
go.
Awesome.
Great. Okay. So we're going to talk a little bit about Alzheimer's disease and other dementias. I see someone has raised their hand, so I will let Carissa, do we need to pay attention to that?
Yeah, so if you raise your hand, just plop your question in the chat there and we'll be able to answer for you.
Thank you. Okay. So Alzheimer's disease and other dementias. There's many different types of dementias, and this chart is explaining to us that Alzheimer's disease, Lewy body, vascular dementia, frontal temporal dementia, and other are all different kinds of dementias. So Alzheimer's is only one kind. Dementia is an umbrella term. It's describing many different things that are happening. It's kind of like the word cancer. So you can have many different types of cancer, such as lymphoma, breast cancer, kidney cancer, but they're all cancer. It's the same with dementia. Sometimes people will be diagnosed with what is called mixed dementia, and that's when one plus one or more dementias are present in the brain. So they're all mixed in there, can get quite complicated and confusing. All dementias cause physical changes to the brain, and these changes cause changes in behavior. And those are the behaviors that I imagine you're seeing in your work. Different dementias will cause different changes, just as I described. Frontal temporal will have very different symptoms than other types of dementia. They won't always start with memory loss. There's other things going on. So there's many types. It's not normal aging, and it's progressive, and it's experienced in stages. It starts small and gets bigger over time. So we're going to try and understand behavior today because we believe that they have a reason, a cause, and a meaning. So they are an attempt to communicate. They're trying to tell us quite often that there's an unmet need, and that's why we need to pay attention, because if there's an unmet need, if there's something going on, we need to know about that. And they are also sometimes the result of physical and structural changes in the brain. So usually there's more than one thing going on here. That's why we say dementia and an unmet need, or dementia and a need to communicate something. And as I mentioned before, changes are so individual. So each person's behaviors will be unique to them, and they will have a unique message about what's going on for them. We're going to learn today about doing some detective work. And that means watching these behaviors and developing a skill set. And the skill set is about learning what is happening. Is it a behavior that needs to be changed? And how can you help? So by problem solving why behaviors occur, there's strategize ways to respond. We look at what's happening, and then we learn to assess whether the behavior needs to change, because not all behavior needs to change, and not every behavior requires intervention. Sometimes you do need to intervene immediately, and many healthcare providers tell us that they use validation as a first step, and then they move on to distraction. This is a great approach, and I don't want to discourage you from using this approach, but sometimes validation and distraction is just a temporary band-aid for a much more complicated behavior. So today we're going to work with a case study in which validation and distraction are just not enough. We will need to get to the root of the behavior in order to affect any kind of change. And our case study today is really basic example. We're going to meet Nick, a person living with dementia in a care home, who is often not using language to communicate. He is experiencing a repetitive behavior that is occurring over and over again, same pattern on different days, but at the same time. But because he's not talking about what's going on for him, we're having to watch his behavior to understand. So that is Nick on the far right. Now remember, Nick is in long-term care and he's been living there for a while, and the behavior we're watching has been going on for a while, but it hasn't always been this way for Nick. It's something that's just started to happen recently. And while you watch this video, you're going to look for who's involved, where is this behavior happening, when is it happening, how often, and what exactly is going on. All right, so it's who, where, when, and how often. Now, in real life, we would have a behavior log to track this, and I will talk a little bit more about behavior logs after the video. Here we go.
Hi, everyone. I'd like you to meet Nick. Nick is a resident at a long-term care home. Recently, in the afternoons, Nick has started walking extensively. He can walk for up to an hour or an hour and a half. He takes small breaks in the living room area, but he sits on the chair looking sad and distressed. Staff come by and ask if they can help. Nick just looks at them, frowns, and walks away. We know something is wrong. Recently, Nick, on his walk, started telling us he sees animals. We don't see them. We think there's something wrong with his eyes. We know that he's bumping into furniture. Maybe he needs glasses. He's covered in bruises. Lately, Nick has started going into other residents' rooms, and this is a problem. He believes they are stealing from him. He picks up their items, usually books, and walks out. Once again, Nick is having problems because he bumped into the door, got another bruise, and then left. This is a serious problem for Nick, for the other residents, and for all of us working at the long-term care home.
So here's where we start to open up the chat box. Thank you so much, Sarah. And I just want to make sure, and Carissa, perhaps you could give me the feedback. Could everybody hear that video?
Yep, that's great.
Great. Okay, good. So my first question for the chat box is, who is involved? Where is it happening? And when? Who, where, and when? I'm going to rely on Sarah for this feedback. Sarah, please feel free to unmute and just share with me the information you're getting.
It's still coming in. We had one person respond that Nick, staff, and the other residents are all involved.
Great. And that's what makes this behavior so concerning, is that it affects many people. Any wheres or whens?
Yes, we're having a few people say it's happening in the afternoons, it's happening daily, it's happening in the living room, the residents' rooms, and in the hallways as well. So throughout the care home and also into the evenings.
Perfect. Okay, great. And you're all right. And this is part of the skill set of watching a behavior, is learning to really pay attention to these little details. Sarah, I'm going to move on to the next slide unless there's anything else I should pause for.
I think we're good. Everyone seems, yeah, to be on board in the chat.
Lovely. Okay. We're going to talk about describing behavior here, because sometimes we describe behavior in a way that doesn't help us an awful lot. You did great in the chat box, and that's exactly the skill set we need to see for understanding behavior. So on the far left, you're going to see a bunch of generalizations. These are the words that we are discouraging because they don't help us understand. So if we say Nick's wandering, it doesn't really tell us much. Or if he's sundowning in the afternoon, well, what does that mean? It's different for everybody. He's uncoordinated, he's bumping into things. Yes, but there are more details. Uncooperative, agitated, maybe he's depressed. Those could all be true, but the thing is, they don't give us the facts we need. So let's go to our best practice side of this chart and look at the specific person-centered language. Nick is walking 60 to 90 minutes, entering another resident's room, and he's specifically taking books from one person. You didn't know her name, but we do, Mrs. Lukowski. We know that this behavior starts around 3 p.m. and it's a mood change for Nick. He's walking and searching, happens right before dinner, and it happens at least twice a week. We see Nick bumping into a dresser and a doorway. He usually hits an arm or a leg, and he has bruises. This is very important detail. And he's not responding to verbal offers of help. 2 people in this video tried to help Nick, and he did not respond. He wasn't interested in even connecting with them. He's walking away from his nursing carried on the floor, all the while frowning and grimacing. So Nick is also seeing animals in the afternoon when it's getting dark. Now, we don't know why, but Nick is actually able to talk about those animals. He's able to communicate that he sees animals. So this is our detailed describing behavior list. Person-centered language is actually quite factual, as you can see on the right side, and the words on the left are more like labels and generalizations, and they can also have negative considerations. If you say, oh, he's wandering, it indicates that, well, that's Nick's dementia behavior, and, Nick has a problem. Actually, we're going to hear Nick's side of the story and what's really going on for him in a couple of videos down the road. So we want to lean towards the helpful descriptions on the right-hand side in order to be a detective. The primary influences on behavior are many, but we focus on physical, communication, environmental, and task. So physical factors are like, well, we're tired, we're not getting sleep, we're ill, we have the flu, maybe we have a UTI. These are physical changes in the body that affect behavior. Many of you will notice if you're caring for a person living with dementia who has a UTI or an infection, their behavior is often the first clue that something is not right. Environmental factors such as the amount of noise and light will also influence behavior. Not everybody knows how much the environment in fact impacts a brain with dementia. Things like light, noise, glare, reflection, color, all affect that brain and therefore influence behavior. Task-oriented factors include how well we are able to complete a task such as getting dressed, turning on a TV, writing a letter. So changes to our ability to complete or participate in tasks affects behavior. And finally, the big one, communication. And I know you all know this. Communication influences connection with others, and the ability to communicate or the loss of ability to communicate or understand others directly impacts not only our relationships, but our behavior. So we're going to learn Nick's side of the story here. This is a person living with dementia. Nick's going to narrate his perspective on what's going on for him.
How can the fire alarm go on so long? Over and over again? Ugh, I have a headache. I just want to find a place that's quiet. I want people to leave me alone. Oh, it's him. I've seen him before. That's it. I'm leaving. Find a place. Find a place. Wow, a rabbit. How cute. I had rabbits as a kid. Ow, where did this thing come from? Who would have put it there? How stupid. This is a walkway. That really hurt. I need to find something. Oh, I thought I could rest here. Hey, that's my book. I've been looking everywhere for this. Ow. Oh, hurt all over.
So that is Nick's side of the story. Sarah, I'm going to open the chat box for a second and just see, was anybody surprised at what they learned from Nick?
Yeah, we'll just give it a minute or so here for some responses to come in.
Thank you.
So Regina shared, not surprised at all. Regina, I'd be curious to hear a little bit more about that, if that's sort of something that you're expecting from his behavior. And then others have shared that he was concerned about the fire alarm, that it makes sense, except for seeing the animals, that might not have made sense to a few people. And then Casey shared that he's also experiencing auditory hallucinations in addition to visual. So connecting that he has some hallucinations going on as well as the rest of the behavior there. and that he doesn't fully understand what is going on.
Wonderful. Great. I love it that somebody was thinking about auditory hallucinations, because that's absolutely possible. And it's something I actually hadn't thought of until you said it. So thank you for that. That could be happening as well. And that would make sense because we know that this behavior is occurring over and over again with Nick. So it's highly unlikely that a fire alarm is going off every couple days at the same time every day. But there's probably other noises that Nick might be mistaking for a fire alarm, or he could also be having auditory hallucinations. So thank you so much for that comment. So the first thing we learn from Nick is noise, and we don't know if it's real noise or if it is an auditory hallucination, but part of the detective work is trying to get to the bottom of that. What is that noise, and do we have any control over it? So what happens at 3 o'clock every afternoon in long-term care? Well, it could be a noisy time. There is a shift change around here. There's a lot of coming and going. But there's also a lot of sounds in long-term care that we get used to hearing every day. But for a person with heightened sensitivity to noise, it could be very difficult. Thinking about bed alarms or the door alarms, the elopement alarms, all the noises that go on, the beeping that some of the machines in care cause. So the environment is the first trigger for Nick. It is noise. Not all noise, but certain tones and sounds can be very comfortable and even painful for people living with dementia. So many noises could be triggering. It could be loud talking, TV. It could be a TV show about a medical emergency and he's hearing a siren on that show. But in addition, there's loud noises such as people calling across the hall, loud kitchen noises, bed alarms, the wander guards. There's just a lot of sound in care sometimes, and all those could be very difficult for Nick. The second thing that we need to pay attention to in our detective work here is timing. So let's talk about the importance of timing, because many of you will know the term sundowning. And we've actually switched that term a little bit. So sundowning is now referred to late day confusion. It's an increased confusion that can and does occur as the light changes at the end of the day. And there are many reasons for this, but let's not jump to conclusions and just say, oh, this is late day confusion for Nick. It could be so much more. Nick could be having a problem with medications, sleeping. He could be dehydrated. We know he's in pain because he tells us he has a headache. So while this could be late day confusion, it could also be so much more. What about Nick's sight? Well, we don't know exactly what's going on, but we do know he sees rabbits. That could be hallucination, but it could also be what we call a visual mistake. When someone's living with dementia, their eyes may work perfectly, but the eye sends a message to the brain, and the brain gets the message mixed up. And that's what we call a visual mistake. Visual mistakes happen more often in the late day when shadows and darkness change, so in late day confusion time. And they happen more often because it's easier to see and make mistakes with shadows at that time. Nick was looking out the window when he saw the rabbit. That could have been a dark shadow or a murky movement in the wind. He could have mistaken that for a rabbit. So we don't know exactly what's going on with Nick's vision, but there is something going on because he's bumping into things. Nick bumps into a dresser and he bumps into a door. So it's important to pay attention to those and wonder why those? Why is he bumping into those? And it's probably something to do with color, contrast, and depth perception. Dementia will affect Nick's ability to see how close and far things are. So going up and down stairs, moving through doors, navigating hallways. Nick's brain has to be able to determine how far to stay away from an object and when things aren't safe. And if Nick doesn't have that ability anymore, he's going to start bumping into things. Finally, we have changes in Nick's mood, and this is understandable. Nick's mood changes are not surprising. He's in pain. He's frustrated. This is happening more and more. He's continuing to hurt himself. He's continuing to experience irritation from the noise, which is a trigger. And he's likely experiencing exhaustion because he's walking extensively. So I think you will agree if we label Nick's behavior as just sundowning or depression or wandering, we're on the wrong track and we've missed an opportunity to help him. We have some slides here, and when you look in the chat box closer to the end of this presentation, Sarah's going to pop in some learning links for you. And one of them is to a publication called Building a Strong Foundation for Dementia Care. It's on our website at the Alzheimer's Society. And that will guide you through these slides that I'm going to go through very quickly today. When you're doing your assessment, when you're learning to be a detective, you are going to consider the environment. You're going to consider the physical impacts that could be affecting someone's behavior. You're going to look at tasks, too easy, too complicated, loss of initiative. And you're going to look at communication. And we all know communication has a major impact on dementia. And we know Nick was not communicating with us about what was going on. That's why we're having to be detectives. One thing Nick did communicate very well without words is his body language. His frowning and grimacing told us something was really wrong. And at the beginning, you looked at Nick's face, and even the narrator recognized that he was not well because of his facial expression. And that's important communication. So I'm going to stop. We're going to think about Nick here for a second, and we're going to think about what would happen if we did not do our detective work. And Sarah, I'm going to invite the chat box here. What would happen if we did not do detective work for Nick? And we just maybe validated, oh, Nick, you must be having a rough day. And we distracted, why don't you come and have a cup of coffee? What would the long-term outcome be for Nick?
So we're not seeing any responses in the chat box just yet, but if others would like to share, please feel welcome to, and we can certainly raise them up. There's no right or wrong, so just any thoughts that you might have, you're welcome to share those. Um, oh, we have some coming in. So more frustration for Nick, continued bruising and pain. Absolutely. So there's some physical implications there. Feeling unheard, continuing to decline. He may continue to hide. His behavior may escalate to elopement. So there's some safety risks there. Great response. He could get injured. And then more harm, more increase in anxiety, more agitation. So really a general escalation of the behaviors that we're seeing here.
Thanks, Sarah. And you're absolutely right. That is exactly what would happen for Nick. And then, of course, the effect on staff would be huge in that circumstance. And so getting to the bottom of the problem and doing the detective work, we think is really worthwhile. I mean, Nick helped us. We were able to kind of see Nick and learn from his perspective. But if we stopped and worked as a team and did a behavior log on Nick, which means we're all watching and contributing to the log and learning from each other, we would probably be able to identify that noise, or at least when Nick thought he was hearing that noise. That's important information. Look for triggers in the environment that could be starting the behavior or that led to the behavior. We would also, through our detective work, realize a pattern of what Nick is bumping into, and if there's certain things he bumps into repetitively. So if it's always the dresser, what is it about that dresser, or what is it about that door that Nick can't see that properly? And quite often it's color and contrast in care, because if you have a beige door on a beige wall with a light beige floor, well, that brain that's living with dementia is going to have an awful tough time seeing that because there's no contrast. So the detective work would help us understand that. And then, of course, the detective work on other things going on with Nick's overall wellness is important, like if he's tired or dehydrated. And if this behavior goes on for much longer, he will be tired. He will be exhausted. And you're right. The person in the chat box indicated injury is a possibility. That's where Nick is going. He's working his way towards a fall. So
Susan,
thanks.
we've
Yes.
gotten a couple of requests in the chat box. If you can speak a little louder or perhaps move your microphone
Oh,
a little bit closer, just coming across
so
a little
sorry.
quiet. That's
Okay.
okay. Thank you.
There we go. Thank you. Is that better?
Maybe just a little bit louder, please.
I'm going to speak a little more loudly.
There you go.
There we go.
Thank
Okay,
you,
good.
Susan.
Thanks, everybody. So for our summary today we learned that behavior is a form of communication that conveys important information, that we need to support a change in behavior, and that we need to take on the role of a detective. Behavior is a form of communication, and it will help us provide more quality of care and increase safety for people like Nick. By observing and describing behavior using person-centered language, then we can look at triggers and we can look at influences that may be contributing to the behavior. You might not get this right the first time, and I want to just stress that that's okay. It takes time to develop this skill set. It takes time to work as a team and to be a detective. However, through behavior logs and working together, you can help each other to observe, record, and then make decisions on how to support. Dementia care requires a holistic approach, which means we focus on the whole person, which includes focusing on brain health. And someone like Nick really needs that focus on his overall wellness and enhancement of his well-being. Is it worth the time and effort? Yes, we believe so. Nick was not only in pain, but his behavior was affecting him. It was affecting other residents and staff, and you all noticed that. And that's a serious problem, especially in a long-term care environment. So as we're practicing observing and describing behavior and looking at what affects Nick and others around him, we realize that he's at great risk of falls and that he needed more than validation and distraction. Consider the 4 influences on behavior as you go, and please check out our Building a Strong Foundation link in the chat box to help you do this. Work as a team and keep learning about dementia. People living with dementia rely on their care providers to notice, to take the time to observe, to understand their needs, and ultimately offer meaningful support. We're going to stop here. We have a short questionnaire and we have time for Q&A, but I just want to make sure you know how to find us. The Alzheimer's Society is the only province-wide organization in British Columbia that is completely dedicated to supporting people affected by dementia. So that means you as healthcare providers, it means family care providers and friends, and it also means people who are living with dementia. We are here for all of you, and we want you to reach out and stay in touch. So you're going to see the first link Dementia Helpline on this slide, and this is the best way and the fastest way to get hold of us if you have questions, concerns, you want to continue your learning, you're not sure where to go. Maybe you have a situation you'd like to talk through, or you'd like to find some resources to share with a family member. Please give us a call. Okay, we're ready for discussion and questions now.
So we haven't had any questions come through the chat box just yet, but I want to put it out there that we have 15 minutes. So this is your chance to get any of those, oh, I wonder about this with dementia, any of those questions out there in the open. It's free range here, so we're happy to answer any questions you might have. About this topic. This is sort of an introductory webinar, but we can also take other questions that just might be on your minds. Perhaps something happened in the last week and you'd like to chat about that. Yeah, so please feel free to raise your hand, or if you want to sit on it, like Susan mentioned, there's that Dementia Helpline number that you can call if you have questions at a later time. Oh, Susan, there's a question in the chat. Will you be following up from here with more in-depth oh goodness, seminars, with more in-depth seminars? Struggled a bit.
Um,
It's Monday.
yeah, that's okay. It's Monday. There's never enough coffee on Monday. That's a great question. Thank you so much for asking that. We do have another webinar coming up. It's slightly different from what you're asking. Our next webinar, I'm just going to check my date here, is on November 27th, and we're just going to be talking a little bit about young onset. So when you say more in depth, I'm thinking you probably want to move in for strategies and problem solving. Is that what you're asking for?
So while we're getting some more follow-up on that, so we have some great questions coming in fast and furious
Okay,
now.
great.
So we can loop back to that question. There was another one. Any suggestions for frontal lobe dementia who is no longer verbal? So a person
Yeah.
living with dementia who's no longer verbal and how we would support that person.
Yeah, such a challenge, and it's so tough. So when you're trying to connect with somebody who has lost their communication verbally, there are a few things you can do, but it really does depend on the person. So my first comment for you would be, if possible, try and just get one or two care providers, direct care providers supporting that person. So not a whole pile of different people, but just one or two people to really get to know that person. And then to start with things like, well, if I write this down, if I show pictures, if I have a picture board, will that help? Are gestures working? Can I get to know this person well enough to understand their body language and to recognize their facial expressions? Can I get to know this person well enough so that I really know their routine, they really know me, and we start to just develop a rhythm together as we provide care. Now, I'm not sure this is the information you're asking for, but I think it is trial and error. And I do know people who have used picture boards as a tool, and sometimes tech can be used as a tool as well, like showing a picture on a tablet and saying, is this what you want? Showing a picture of a toilet, is this where we need to go? Those kinds of things. But please give me feedback in the chat if that's not quite what you're looking for.
Great. Thank you, Susan. And then to the other question asking about the in-depth seminars, Stephen said, yes, I think something a little bit deeper is
Okay,
kind of.
yes. Thank you. Yes, this was very introductory, and we do not have a follow-up webinar here with Safe Care BC, but I would encourage you to go to our website because you are going to see more learning there. And we also have an on-demand page on our website, which means all the videos we've offered, oh my goodness, over the last 2, 3, maybe 4 years are on there, and you can watch those videos and learn. Some of those are more in depth. They're organized by topic. So I would have a mosey over there. Just take a look and see what we've got.
Great. So there's a few questions in here. So one is from Lelani. When is the right time to connect with a family doctor and case manager? Um, so that's a big question because we know the right time can vary depending on the person and the circumstances. Susan, did you have any thoughts on that question?
Yes. Alini, I think you might be asking as a family support person, but I think early diagnosis is very important, and I think it is under-recognized. So when a person receives an early diagnosis, that means the family can start to understand and prepare, and the person living with dementia can be part of that process, and that's really important. So don't delay. We have some information on our website about the importance of early diagnosis and how to work with your doctor. And one resource I love giving to families, and I'd like to make sure you get this, so please call the helpline, is a checklist. And the checklist lists all the symptoms of dementia that could be happening in the person you're caring for. And then you take that checklist to the doctor, and then you're able to have a really meaningful conversation about what's going on.
Great. Thank you, Susan. So there's another question from Kristen. We hear about people becoming mean or having extreme personality differences. What stage of dementia would that be?
Yeah, that's a great question because it can be any stage, and it's not just dementia. it is dementia and or dementia or. So somebody can become mean. Let's look at Nick, for example. Let's say that we don't do our detective work for Nick. And after a month, we look at Nick and we think, wow, he's got really mean. Well, that's actually not dementia. That is a situation, a surrounding that's not being dealt with and causing problems for Nick. So being mean could be considered a behavior. And then when we look at behavior, we have to invest and we have to go into our detective work and see what's going on there. It can happen anywhere at beginning stages, mid stages, late stages.
Great. Thank you, Susan. And I'm just going to jump over to the Q&A box because we have a couple questions coming in over there. One person asked, Jane asked, do you have resources for people who have developmental disabilities and dementia?
Thank you for asking that question. I think we are psychically connected because I'm just working on that. I just started to build some resources around that. I attended an amazing conference presentation around disabilities and dementia, and I just gave a presentation to a group home about that. So if you reach out to the email on that slide, I'm just going to go back. I will get you that information and I'd be very pleased. So there's an email here, dementiaeducation@alzheimerbc.org. Please reach out and I will share everything I have with you.
All right. Thank you, Susan. So it sounds like that's still an in progress thing. And we hope to have more resources on that topic in future because it is one that we're learning a lot more about as we go. So there's another question here from Stephen. Dealing with vascular dementia seems like its onset is quicker than most. Do you see more of a specific precursor?
Stephen, when you say precursor, I'm not quite sure what you're seeing or referring to there. Because you're
I,
right, it is a sudden onset because it's after an event in the brain. Sorry, go ahead, Sarah.
so I think I'm interpreting this as any sort of risk factors or any signs that vascular dementia could be a risk to somebody. Stephen, correct me if I'm wrong. So, hypertension, high blood pressure, that sort of thing. Um,
Mm.
And Stephen, if that's not what you're asking about the risk factors for that, please do let us know. But vascular dementia, you're right that it can come quicker because it happens when there's a vascular event in the brain, like a stroke or a TIA or whatnot, and it can occur with mixed dementia more often. So we might see it with Alzheimer's disease. Perhaps somebody has a bit of a quicker decline. It might seem like it's out of nowhere. And to Susan's point, that's where we put on that investigator hat, rule out some of those more physiological pieces that we would look for to see if vascular dementia is something that we're paying attention to at this time. But Susan, if you wanted to add anything to
No,
that, please do.
thanks, Sarah. Yeah, I'll be interested to know if we've actually answered Stephen's question, but thank you.
Yeah, Stephen, let us know if we've completely missed the mark and you still have your question. We're happy to come back to that one. So Anne is asking, how do you identify if it's dementia, if the person is not showing the normal behaviors associated with it, but you know it's dementia, as the individual is not wanting to do their own routine without being told, as the individual forgets what time of the day it is?
Right. Such a frustrating situation and very, very difficult. So I think when you suspect it's dementia and you're seeing those symptoms, it depends on your role or your relationship with that person as to what you can do. And also you have to ask why. So if you are related to that person, if there is a relationship with that person that is not professional, you will want to support them in all aspects of their health, and that means getting a proper diagnosis, right? And I mentioned how important a proper diagnosis is as early as possible. The challenge there, of course, is that if you're supporting somebody who doesn't realize that they need a diagnosis, that's very tricky. And that's where our helpline can help you with some strategies for kind of getting into the doctor's office and having that conversation. Now, there are times when a person may have dementia and be diagnosed with dementia, and everybody knows it except for the person living with dementia. And that's because that there's been so much change in their brain, they've lost insight. They can't actually see. They're not aware that they have a cognitive change. Now, that is a circumstance we usually recommend that you just let that be. There is no point in getting to an argument with somebody about their cognitive ability or cognitive changes when they've lost the insight or they're losing the insight about what's going on. It's far more supportive to be able to connect with them and not correct. So connect, not correct. Have I answered that question?
I'm going to say yes. And then if we haven't, please let us know in the chat. But I think that was a beautiful response, Susan. Thank you.
Okay.
And then on Stephen's question about vascular dementia, so yes, that answered his question. Then he had also asked about symptoms, which is a question that we get asked often. What are the symptoms for vascular dementia versus Alzheimer's disease versus other types of dementia? So I think it might be nice to maybe just speak quickly on sort of where there's a bit of overlap in the symptoms and how sometimes it can be difficult to discern one type of dementia from another.
Yeah, okay, for sure. So with vascular dementia, because it is the result of an event in the brain where the brain is deprived of oxygen, it can come on much more suddenly. So with Alzheimer's, you might see slow, gradual changes that are just usually mistaken for somebody's normal aging process. And vascular is usually a bit more sudden. And while Alzheimer's will present with a short-term memory loss as a first step, vascular not necessarily. It really depends on where the damage is in the brain as to what the symptoms will be. Because if someone is having a series of mini strokes, like TIAs, or if someone's having a major stroke, we'll see very, very different symptoms. So after a major stroke, you may see the facial paralysis, you may see problems with communication and language, but no memory loss. Right? Or with a series of small TIAs or those small baby strokes that they call, you may see something that's subtle at first but grows over time. And that could be things in emotions and mood changes or judgment calls, like actually making decisions and making smart decisions or safe decisions could be affected. So it really depends where the damage is in the brain as to what the symptoms are going to be.
Wonderful. Thank you so much, Susan. Um, and we're seeing a lot of thank yous in the chat box. So I think this is a great time for us to segue into our quick request for you, which is before you go, we have a couple poll questions that's very helpful for us to gauge if this webinar has met the mark or if there's other topics or other things that you would like to see. So if there are topics you'd like to see more webinars about, please let us know in the chat. And also please just take a moment there to answer the poll question that just popped up on the screen before you go. So perhaps it might be helpful. I could also read out the questions there. Just let us know if the webinar was relevant to your work. Yes, somewhat, not really. I feel more confident in my ability to understand behavior. My knowledge has increased, and I will be doing some things differently as a result of my learning today. So these questions are very helpful for us to structure the webinars in a way that works for you. We want to make sure that not only do you get information, but you know how to apply it. So once again, thank you for taking the time to respond to that poll question before you leave.
Thank you again, everybody, for joining us today. We hope to see you on November the 27th for our webinar about young onset dementia. And please do reach out and connect with us via the Dementia Helpline and the email that we provided. We would love to hear from you.
Thank you, Susan. Just before we click off today, I'm just gonna replace your share and mention some more upcoming events. What we have here. Second. Yeah, so yep, this. Yeah, so on November 6th, we have staying emotionally healthy in the workplace. And those always happen over the lunch hour, so that'll be 12 to 1 next Thursday. We have a few other emotional intelligence webinars, and like Susan said, we had the second part to this dementia in focus, but that one has more focus on young onset dementia, and that will be on November 27th. So please stay tuned for that, and I'm sure it'll be great. But thank you, Susan, thank you, Sarah, and thanks everyone for attending and engaging with us this morning.
My pleasure, Carissa. Bye-bye for now.
Bye.